Fabulous. So welcome everybody. So we go straight into apologies. Helen, do you want to give us an update?
I have apologies from Toby Sanders and Bev Messenger.
Fabulous, thank you. And one thing I want to mention at this stage, as we move into the new ICB shadow arrangements, the patient representative position isn't going to continue post the end of March. So this is David's last meeting. So just on behalf of the committee, David, I wanted to thank you for your participation. So many thanks.
Thank you. Sorry it's happened, I'm afraid. Never really got started.
Well, but thank you for all your efforts and attention and contribution. So we move on to declarations of interest for items on the agenda. Any declarations? No. Okay, and then to the minutes of the last meeting. Rather than go through page by page, has everyone read the minutes, and are there any amends or changes that people would like to put forward? No. Okay, so we go to matters arising and action log. The action log is up to date. So are there any matters arising? Romping through, so we move straight on to item 5, which is Chair's update. I just wanted to draw attention to the recent audit that took place in Q3 of the financial year. For people who aren't aware, the primary care delegated authority is always audited by external auditors once a year. I can happily report that was a positive audit with reasonable assurance that we are fulfilling all of our statutory duties as a primary care committee and the primary care team in its delegated authority. In terms of, they tend to group actions into high, medium and low priority. We had no high priority actions. We had one medium priority action, was around a needs assessment, and then a couple of low priority areas. So I think on behalf of the committee, I'd just like to thank the team for all their efforts in ensuring that was a positive audit and continuing to fulfil our statutory responsibilities. And from a committee point of view, it's really reassuring that that's 2 years on the trot. We've had really good audits to show that actually we're being marked by external auditors and we're doing the right job. So thank you everyone involved. So we can move straight on to Kieran and item 6 and the GMAST update.
Good afternoon, everybody. It's a very short paper today. I'll take it as read. In terms of highlighting one specific area that I wanted to just, I suppose, raise awareness on is the planning guidance and the operational planning round. And we've seen changes over the last few years in that primary care often wasn't part of the activity side of things. And I know Stuart will say it's very much part of the finance side, but in terms of the activity side, it's been a growing influence. And so in terms of the primary care figures, we have looked at the activities again. And obviously, when we looked at this last year, it was based on 2019 activity. We all know, based on information that you'll have seen through governing body and other updates, that the activity seen through primary care is far and away above 2019, and obviously is definitely above last year's. And I raised this in deputies yesterday that we have to be very cautious with primary care, in that that this is a contract based on capitation and it's not activity, and therefore the planning projections that I've put in so far, and it's just draft, have been still based on 2019 and not any growth. And conversations Julie and I had were that they were the appropriate levels of primary care at that particular time, and that's why we profiled it last year. And it would be foolish to expect that growth that we've seen this year to continue, because that's very exceptional circumstances and isn't sustainable. And going back to the previous point, it's not an activity-based contract. So I just wanted to raise people's awareness on that just quickly, and I'll pause for a minute if anyone's got any specific questions. But that's the only bit I wanted to raise in the GMAST update.
Okay, so we open it up for comments or questions. No comments. So from that, we can take assurance. Thank you, Kieran. I believe that you're up for the next item as well, which is the COVID mass vaccination update. So straight over to you again.
Yep. Okay. Thank you. Okay, so I've taken some of this update from the governing body paper that's at the back of the document. So, in terms of 100% of care homes now received a visit to ensure residents have received their booster with that general practice support, and that continues to make sure that any new residents are picked up and off the vaccine. Home visiting service and general practice have delivered the booster to all of our housebound patients, and now in the process of contacting any of those that would have been in hospital to pick those up to make sure that those patients also receive their booster. The next challenge is moving to the younger cohorts and the 5 to 11s, for example. Not all the LVS sites are offering that service. However, there are two main sites, north and south, that are picking up where LVS sites aren't all signed up, but that's a similar process that we've seen for this extended cohort. So it's consistent with what we've seen previously. Anyway, further update that came very recently from Chris Pallow. Chris and Julie met yesterday. All ICSs are being asked to look at their plan for delivering the autumn vaccinations, and that's the 75 and overs and the 50 and overs. I think the regional view, paraphrasing how it was explained to me, was that potentially systems should not be reliant on primary care, and it maybe lean towards the pharmacy sites and the mass vaccination sites. Chris Pallow's view as the SRO was that it should still be a complement of all, and he's had a meeting with the clinical directors today to have that conversation with them to make sure they're in agreement with that. In terms of the ask, it's very much around profiling where the capacity would be in the system based on two scenarios. One is almost a standard program of work, so we're not in COVID anymore. It's more of a standard vaccination program, something that primary care are well experienced at delivering. And another is, are we back in another strand and things are stepping down and therefore we're prioritising boosters, for example. So they're going away, and Chris has met with them today, and I've seen actually the summary of the meeting that clinical directors will go away and work on that between now and Monday to provide the answers so the system are able to put their response back together. And I think the final thing on the COVID vaccinations is just a bit of an update on numbers. So this came through today. So this will be as of yesterday. So year to date, there's over 1.4 million, just under 1.5 million doses administered, and 1.1 of those have been in primary care. Around 800,000 of those specifically within the LVS sites as well. And I thought it might be useful to demonstrate the breakdown of those vaccinations in terms of first jab, second jab, and booster. So there's over 500,000 first jabs. There's slightly less second jabs, but there's also over 400,000 boosters now. And interestingly, there's 7,000 that are classed as third vaccination. So that's to do with the definition of high risk and those that will then get a fourth. But just you might be curious to see the sort of makeup of those vaccinations over the different stages that we've had. But I think that's it from the COVID vaccination update. Again, I'll pause and mute myself.
Any questions for Kieran on vaccinations? Nothing joking. I've got two quick questions. One is around the speculation around boosters in the spring for over 75s. Do you know anything about that, Kieran?
I would say that based on the meeting that's happened today with Chris and the planning, it's still planning to be the autumn. That's all I know as it stands at the moment. I'll feed back to Chris to see if there's any intel that might suggest anything other than that.
Okay, and the other thing that I was picking up was there was some concern within primary care that the batch sizes were still quite high, which is leading to some wastage when there are reduced numbers attending clinics. I'm not sure if that's something that has been picked up or has been felt across the piece. I know Sanjay's just put his hand up. Was that on that point, Sanjay? Do you want to come in?
Yeah, so there's two batch sizes. One is you're talking 1,000 in one go, and the other one is approximately 300. There is still a risk of wastage, and a lot of sites are ordering the smaller packs because despite best efforts through all forms of communication with patients, as restrictions have lifted Patients' drive to get vaccinated has taken a massive dip, and so clinics aren't filling as easily. So we're pulling in the smaller packs to minimise the wastage, and also the packs have a 4-week shelf life on them, which is much better than it was before. So with 4 weeks that you can keep it in the fridge, all the sites and the MassVac site are trying to tailor the clinics to try and get in as many people as they can, try and encourage them. At the moment, the drive is on the boosters for those who had a third dose. That should be a pretty well, that should be an easier one to pull in than trying to get the public in who are otherwise fit and well and just need to be vaccinated. But we're trying to minimise wastage by we call them the baby packs because they're smaller packs. So we're trying to minimise by using more of the baby packs. If that helps.
Okay, thank you. Joe.
I can help with the spring booster question because I was on the national webinar yesterday, if that's helpful. So the plan is that there will be a spring booster or a somewhere between April and June booster for the over 75s, the immunosuppressed and care home residents. It should be approximately 6 months after. It will not be for health and care workers, and they were very, very clear it won't be for them. And then obviously the details of the autumn one are still being worked up, but the plan is that those people will have an additional. It was noted that the terms that we use are incredibly confusing because some of those people will be on their 5th vaccine by the end of the summer. And what do we call it? And there has been a recognition of that at a national level that we need to be really clear. But the group that will be having a late spring, early summer will be the over 75s, the immunocompromised and the care home residents.
Thank you.
And the immunocompromised will be over 12s.
Hot off the press. So I'm assuming that will feed back into Chris. Great. Any other comments or questions for Kieran? Okay, thank you. So I know we've got Donna and Sam here, so we move on to item 8, which is the general practice IT update. Do you want to give us take the paper as read and give us the sort of key headlines, if you would?
Hello, everyone. So yeah, thank you for allowing us the opportunity to come along and present the paper. We've included within the paper some of the key points over the last quarter. So we previously presented a larger paper that was covering a sort of wider period of time, but the paper that we've submitted this month is covering just the last quarter. We've summarised some of the key points around what we've delivered and what we're planning to deliver up until the end of this financial year, but also some of the key work streams that we have being delivered currently, and just opening it up to the group if there's any questions or any concerns that you'd like to feedback, and hopefully between Donna and I we can answer those for you.
Okay, so open it up for comments and questions. Sanjay.
Thanks, Sam and Donna. The paper covers a lot. There was 2 quick queries. One is, come April the 1st, PCNs are going to have a sudden, well, I say April 1st, it'll be within a few weeks, an influx of PCN staff, which are going to require more IT equipment. And there always seems to be this, the staff arrive and the equipment takes a while to get there, which means they're almost sitting there not being able to do much. So has that been incorporated into the plans? That's question 1. Second question is, the new equipment and that's coming around, I'm very grateful for that. The printers especially, thank you so much. The problem we're having is the new stuff is coming really quickly and the old stuff just isn't taken away. So we've got rooms that are blocked now, clinical rooms, because the basement's full with these huge printers. I'm sure Joe and Amar know what I'm talking about, but they are really big. Is there any plans to try and speed that up? Because that would also free up some much needed space in practices. They're my 2 questions. Thank you.
Thank you.
Thanks, Sanjay. With regards to PCN staff, we would normally get PCN. Are you talking about laptops, Sanjay? Or is it?
Well, it depends on what the PCNs need. So I'm not specifying laptops specifically.
Okay, so for PCN laptops, the CCG funds the PCN laptops if they're for the Rs roles, and they are actually kept at the moment at Francis Crick House, so they're usually turned around pretty quickly. So there isn't usually, that would normally be quicker than a your usual request for a laptop. If it's equipment that the PCN are purchasing themselves, and there is still a delay, so if the PCN are paying for it, there is still a delay for all equipment. Obviously printers, there's a huge delay, but even for laptops, desktops at the moment, it's just a knock-on effect of COVID and Brexit. There is still a slightly longer delay, but they are still coming through within a couple of months. So it just really depends on when they're being ordered. So we would encourage, obviously, people to order their equipment as soon as they can. Does that help with that question? With regards to the kit, the kit being removed, we do have a disposal process, as you'll know, and yes, it does involve storing the equipment at practices. If there are any concerns with that, if it is taking too long, then please do get in touch with Sam or I, and we will push that along. The other thing, just linked to disposals, is that we are aware that there are some practices across the county that are at the moment sort of entering into a managed print situation where they're having new printers installed that aren't now provided. If that's the case, then we may not know that there's kit sat there waiting to be picked up. So again, we just need to double check that there is a call, so it needs to go through the service desk, that there is a call there waiting for disposal of that equipment or reuse. So if it's equipment that can be reused, then we'll do that. Does that help?
Joe.
Thank you. I wanted to raise here, it's more of a national issue than anything else, but I wanted it here and I wanted it minuted. There are still significant concerns about the patient access to records scheme that has come back again, that's due to be authorised for next month. I appreciate this was shelved before Christmas. It has the potential to create huge amounts of IT work, prospectively, retrospectively, significant safeguarding concerns, which to my knowledge have not been rectified when they were raised and the project was shelved in December. I wanted it really recorded. I'm not expecting you to answer the questions because I appreciate this is national, that I still have significant concerns about the wisdom of going live in April, that I think a number of practices have concerns about the prospective and retrospective access to records, and none of the changes to my knowledge have been implemented within the clinical systems that would allow those safeguards to be put in place. So I'm not expecting a solution to it. I appreciate it's being escalated by a number of us. I can see a number of different hands going up, but I wanted it put on record that I think this is a significant IT and safeguarding risk should the national NHS digital project continue without those safeguards in place. Thank you. I'll get off my soapbox now.
Thank you. So I'm going to take in order. So Julie's next with a hand up.
Mine wasn't about this point, Andrew. So if everybody else would like to respond to Joe's point, then I'll come back in.
I'll come back to you. So Karen was next up.
It was just to say I've also raised it through the NHS digital routes, and well, I wasn't the only one. All systems, so all 11 systems raised it and raised those concerns that you mentioned. And I haven't heard back, and I couldn't make the meeting this morning that was at 10 o'clock. There's another one, so it might just be I need to touch base with what was on the agenda today to see if there was an update. But it was a consistent concern raised by all regions, so I'd say that, yeah.
Okay. Naomi.
Yeah, thank you. And I would echo Joe's concerns, having just been on one of the national webinars at lunchtime today. The big question for me is around the training. There seems to be a misconception at a higher level that we're already doing this in terms of redacting records as we go along, and consistently the question's been asked about training, which has been, well, it's no different to what you're doing now. It's a huge training issue, and it's whether we are going to be expected to do that locally, because there doesn't appear to be any national programme.
Okay, Sam or Donna, do you know the answer to that?
I know that there are, and I'm sure you've been on it today, Naomi, the national webinars that are happening, and we've all sat in on those. Now, we did have a team meeting earlier this week, and we were, funnily enough, talking about this because we've obviously had a lot of questions come into our team about the accelerated access, and we're looking at how we can better support practices. So we need to put together almost like a formal project to roll it out and to help practices. Obviously it's being rolled out and it's being done to practices, but how can we best support practices under the circumstances if it does go ahead in April? So we are looking at that, and we'll be discussing that again on Thursday, in fact. So we will continue, but when we've worked out what we are going to do as a team to support practices, we'll send that out via our clinical systems mailbox like we normally would.
Okay, thank you. Sanjay.
Thanks, Andrew. So it follows on from Naomi's thing. I think we were in the same webinar this morning, 12 o'clock or 11 o'clock, whenever it was. I think there seems to be a bit of a disconnect in what the national team thinks that the clinical systems can do. And the biggest thing that cropped up there was the ability for patients to view results the moment they are filed. And the response to that was, well, you almost just delay the filing part, but we can't do that because CQC would run all over us if we were to do that because it's unsafe. You have to have shown that you filed it, at which point the thing was, well, you hide it. There is no functions in there. So I'm not sure how to escalate it because I put it in the question thing there and that was the answer I got. I've emailed the Futures platform, which is NHSCX, whatever it's called. I'm at a loss now where we escalate this because I think there's a bit about the issue and the inconvenience and the training. Absolutely, that's going to be huge, and I think primary care is going to suddenly see this wave come in of people who are seeing things and are concerned. And I think there's the other bit is causing concerns unnecessarily for patients when they are seeing things that if you had a conversation it'd be fine. Because not everyone sits within a neat little boundary on results. So it's, if anyone knows, Donna or Sam, if you know how to escalate this or point me in the right direction, I'll happily write an email or go through over whichever channels. Thank you.
We can take that away, Sanjay, and
Okay.
and let you know who best to escalate it to.
Thank you.
Thank you. Jonathan.
Yes, likewise, we consider this a very significant patient safety issue for two reasons. First of all, it diverts extremely scarce GP resources onto what is basically an administrative task of redacting records which come into the practice automatically, and any record which references a third party requires a clinician to spend time looking through that, deleting the reference to Mrs. Smith's auntie, and this takes an enormous amount of time. It runs the risk of delaying the actioning and filing of these documents, which is a prima facie patient safety issue. And the second thing is the dogma about this. This is not doctrine, this is dogma. It is dogma that the records are there for the patients. They're not. The records are there for clinicians to record their thoughts about the developing diagnosis on patients. There isn't time to share all of that information with every patient every time. And if the country wishes to make time for that, there would need to be an enormous expansion in GP numbers and GP time to share every little bit of information. And the problem with that is actually for the GPs that are sitting in front of patients every day, most patients actually want to hear the complete story, and they don't want to hear all the possible fantasies of dangerous diagnoses that are rumbling around the back of a GP's mind. And the danger of this dogma is GPs will stop writing in the notes their thoughts, which are there to remind themselves not to forget something when they next see the patient or when they next review the notes. Those thoughts are aimed at themselves as a safety net to make sure that they don't forget something. That's the purpose of the medical records. The purpose of the medical records is not as a sort of public document for people to have a little rootle around for any time they think. And the problem is this is a dogma. It's lunacy in London, and it's time the chairman or chief executives of the CCGs collectively wrote a letter to the Secretary of State or to Nikki Kanani to say, you've gone mad, and if you press this through, on the 1st of April, the way GPs write in the records will be changed forever, and there will be a slew of dangerous outcomes from that later on this year as GPs start censoring themselves about what they put in the records. And I don't know why no one's explained. I don't know why some friendly GP in the Department of Health or in NHS England hasn't taken the minister on one side and said, have you thought about this? Because he's not dopey, and we just need to take action on behalf of people who are going to be damaged otherwise.
And there is a select committee going on about workforce planning today, so I think very pertinent. Amar and then Julie.
Thanks, Andrew. I mean, I think I don't want to go on any more than what Jonathan just eloquently put there. One question probably to Jonathan. I don't know whether the GPC or the BMA have taken a strong enough stance. Really, is one of the things. I don't know whether the LMC have got in touch with them, because obviously this is a national issue. Because it's going to cause a lot of distress for patients in terms of the data that they see. And that's what it is. It is data, because the interpretation of it is by a skilled individual. And I think that's where it's going to create the distress for the patients on the whole, rather than aid anybody in particular in helping them to understand their health, as Jonathan's articulately explained, what the notes are used for. So that was my one question to Jonathan, really.
Okay, Jonathan, if you come back in, because I noticed your hand.
I mean, very briefly, is this meeting recorded, by the way?
It is.
Right, I better be gentle in what I say then. LMCs across the country have raised with consistent calling for the GPC of the BMA to take a stronger stance on this. Whether or not those calls have been heeded is a question that I feel unable to answer accurately. I'll leave you to interpret what that means.
Okay, Julie. You're on mute, Julie.
Yes, sorry. This is a very small point after what we've just spoken about, when you've got this really huge national. It was something that Sam and Donna was talking about disposal of equipment within practices. If practices, can we put something just in the bulletin to say that if you need equipment disposed of, i.e. when I think it was Donna that was saying you don't know if practices have bought their own equipment, for example, they might not know that they just need to contact you. So I just wondered if we could put just a line in the bulletin to say that.
Yeah,
we'll
link up with the primary care team, Julie, and get that in.
And I think, Julie, if you're happy, I think there's such a strength of feedback and feeling with regard to patient records that I think that does need flagging to Toby as a point of escalation. So I think on behalf of the committee, if you could take an action to escalate that with Toby and update on next steps, that would be much appreciated. There was a final question I had, which was around the atrocious position in Ukraine and the obvious impact in terms of potential cyber attacks. Is that something that we are actively looking out for?
Absolutely, Andrew. We're actually being required to submit on behalf of the CCG a submission by close of play. I think it's this week, where a number of actions have to have been taken to provide assurance that we have the adequate protection in place from a cyber perspective, and that's a national directive that's come down via the channels. But you're absolutely right, it is, it is a concern, and it's something that's being picked up as a priority.
Okay. Thank you very much. So we've got a couple of things there. One is around communication and making sure we utilise Bulletin to make sure that all our practices are updated in terms of kit, disposable, access, etc. And then we've got the very important point around access to records and making sure that we're flagging that up as a big issue.
And if there is anything that you'd like us to update on for the next month that you haven't seen in this month, please do just let us know, and we'll ensure that we encompass that for the next paper.
Fabulous. Thank you both for your time.
No, thank you, everybody.
Thanks all.
Thank you.
Bye.
So we move swiftly on to finance, and Stuart.
Thank you, Andrew. I'll do the follow Kieran. I'll assume the paper is read. Just there isn't too much change from previous months. So basically, year to date, 2.1 million underspent. That could raise to just under 2.7 when we get the hours funding, the additional roles funded. Those areas that are underspent can be seen in Appendix 1, which is basically the investment fund, the minor surgery DES, professional prescriber fees, and some of the delegated. But there are plans underway to spend what's left between now and year end, so that money doesn't get wasted. And I'll stop at that point. Take any questions?
Okay, any questions? Obviously noting that there is a private meeting afterwards to discuss some of those underspends. Okay, thank you, Stuart. So we move on. There are no quality items Item 11 is the committee effectiveness review. You have the paper in there. This is a requirement that we have to do for the annual report each year, which is basically an evaluation over the effectiveness of the committee. You'll see my evaluation. This hasn't just been me sitting in a room, it's been done with other non-execs who also attend the committees. I think we've noticed a real improvement in terms of papers coming to the committees. We still have some areas of duplication which we should address going forwards, but on the whole we're saying that the committee is working effectively, and that's backed up by the audit. So if there are any questions, feel free to shout. Otherwise I will be submitting this to the board for approval and inclusion in the annual report. So no comments, thank you. And we talk about review of risk as an item. Are there anything from today's conversation that people want to sort of flag up? I think that the patient records is something that it feels should be flagged up on our risk register and triangulated perhaps with quality, given the conversations that we've had. I'll leave Julie to sort of ponder that one, because it's the quality and patient safety thing which has come through to me from a lay perspective as a significant risk that could be materialising from this decision. Okay, you have the primary care reports for information, but unless there is any other business, I'll have to bring the meeting to a close. Oh, Kieran.
I was going to make one very quick point, but there's probably a second point I need to raise as well. The first is a delegation agreement, draft delegation agreement for the pods, now being known as the pods. So that's the pharmacy, Optom and dental. So NHS England have been working on that for a number of months, and Toby was sent a draft copy last week, which has come through to Julie. It captures the draft proposal of the rules that we'll be following from next year, and then also from the following year in terms of the pharmacy, Optom, dental, but also the further delegation of general practice. I've not had a chance to look at it yet, but Julie and I have spoken about it offline, and the view is that we will. There's a lot of it's 80 pages, a lot of detail in there that's going to, frankly, not mean a lot to many people. But what we'll do is we will go through the document to understand it more, flag the elements that need to be flagged, and then Julie's proposal is to take it to CMT on the 9th of March so that Toby is able to respond by the 11th of March on behalf of the system. A couple of things. There's a draft of the delegation agreement, and there's a couple of things that possibly need raising just to be aware of. So the first is that the agreement does not mandate the establishment of a primary care committee, and the second is that the ICB is now required to include their plans for the exercise of delegated functions and report on the performance against these plans. So there's a couple of things that sort of jumped out to me, but I need to read the full document before fully understanding it, as do others here as well. So I'll pause on that for a moment.
So any questions on pods? No, so we note the update. And then your second point, Karen.
Well, Joe very kindly sent me a copy of a letter that's just landed from NHS England, which is the contract letter for 22-23. It literally has just come through. So again, not had a great deal of time to read it. However, I've quickly skim read it, and there's confirmation of the timelines for extended access within there. So that's the first thing that I wanted to point out, and the actions that we as systems and that PCNs need to take between now and October in terms of preparing for it as well. So it looks pretty significant, I would say. So I just wanted to raise that as truly hot off the press now. And Julie, that's come since our meeting just an hour ago, so where we spoke about this. So I just wanted to raise that as well.
And will that come to committee in terms of?
Yes, yeah, absolutely, yeah. We'll bring that to the committee. Yes, yeah.
Okay. Any questions? Okay. Well, thank you very much for your time. And for those that are joining the private meeting, we'll have a 5-minute break and reconvene at 3:10. Many thanks, everyone.
Thank you.